This is a brainchild of our president, who is immediate past president, Dr. Gooneratne, mainly to upgrade your knowledge. So for this year, this is our 8th Senior Registrar Forum. So without much delay, I will invite our president, Dr. Kumuduni Jayasinghe, to address you all as a formality. Dr. Kumuduni, over to you.
Thank you, Dr. Vimali. Good evening, everyone. On behalf of the Sri Lanka College of Internal Medicine, it's my pleasure to welcome everyone, all my fellow colleagues, our senior registrars and other doctors to another session on this SLCIM SR forum. I would like to extend a special welcome to the speaker today, Dr. Kishara Gooneratne, an expert in the field who will be shedding light on EEG basics, a very useful topic for all of us. Thank you, Dr. Kishara, for sharing your expertise with us today. And I appreciate Dr. Priyamali Jayasekara, our honored treasurer, who is passionately leading the SR forum. Without further ado, I invite all of you to listen to this very important lecture. Thank you very much.
Thank you, Dr. Kumuduni. I will introduce the speaker. Everyone knows him actually. He's a good friend and a colleague, Dr. Kishara Gooneratne, consultant neurologist, and he's a senior lecturer in medicine, University of Moratuwa. Kishara, may I invite you to start your speak? Thank you.
Thank you very much. I hope everyone can hear me. Thank you very much for that introduction. Yes. At the outset, I'd like to thank the Sri Lanka College of Internal Medicine for giving me this opportunity to speak to you on its very basics of EEG. So this talk is by no way a comprehensive one. This talk will basically cover the very basics of EEG and EEG interpretation. So what does the EEG actually do, or what we call the electroencephalography or the EEG machine? What it does is it records potential differences between two electrodes, and these electrodes are generally on the surface of the scalp, and it records the electrical activity on the surface of the brain, and it's actually what we actually sort of record is actually the summation of both the inhibitory and excitatory, or the difference between inhibitory and excitatory postsynaptic potentials that occur across the neuronal membrane. And it's really not a so it's not the electrical activity of a single neuron, but it's actually the summation. As I said, it's the difference between all the neurons that are oriented perpendicular to the surface of the brain or the gyrus, and which is oriented in such a way where the electrodes are able to pick up that electrical signal. So anything that is, say for example, if the electrical field is at 90 degrees to the electrodes, it is highly unlikely that the surface electrodes of the EEG will pick up those signals. So that is actually a disadvantage of using surface electrodes for EEG purpose. But this is as it is a non-invasive method. This is so that it does have its it has its disadvantages as well. But it can be a very useful tool, especially as an extension to our clinical examination. So EEG signals and EEG alone without clinical context is actually quite useless. And therefore, EEG needs to be interpreted with clinical context. And when interpreted with sort of clinical context, then EEG becomes a very useful tool. And it is actually the electrical activity that is produced within the pyramidal neurons, which are actually the neurons which are oriented perpendicular to the surface of the brain, as you can see on this particular diagram. Here on your left, the electrode on the surface picks up the difference between the negative charge and the positive charge, where the superficial excitatory inputs are seen on the surface closer to the electrode. And when there is the summative excitatory input is seen as a upward deflection, which is actually a negative deflection seen on the EEG. Whereas on the right, where the main, there is basically there is a superficial inhibitory input, right? There we see the deflection as a downward deflection, which is called a positive deflection on the EEG, right? So what we see as hypersynchronous discharges or epileptiform discharges are generally negative charges, which means that if the electrode with the maximum negative charge or upward deflection is actually closest to the area in which that potential is actually produced. So that is how the basics of the electrical discharge is detected through the surface electrode of the EEG. Now, sorry, someone can't see the screen. Can everybody see the screen?
I can see. I don't know. I can very well see it.
Yes, we can see.
All right. Okay. Right. So there are standard ways of placing the electrode. So this is the international 1020 system, where we actually place electrodes in a very systematic manner, right? To cover the whole surface of the scalp. We take so the standard is that we take the distance between the inion and the nasion, right? And we, out of the total distance, we divide them in the distance by 10% and 20%. And as you can see, the electrodes in front, the distance between the nasion and the FP1 and FP2 electrodes is actually 10%. Whereas from that point onwards, the distance is 20% of the total distance between the nasion and the inion, right? And this is generally standard. And as you can see, there is a standard nomenclature of these electrodes as well. So F would mean frontal electrodes, C would mean central electrodes, T would be the electrodes over the temporal region, so it's T. P would mean the parietal electrodes, and O would mean the occipital electrodes. Now, and it is also numbered in so the odd numbers would be basically the electrodes on the left, and the even numbers would be the electrodes on the right. So these are standard. This is how. Sorry, they cannot see. I don't know why. There is another message that they cannot see the screen.
Ishan, we can see, maybe we are panelist.
Madam, I'm joining as a, attendee also. Attendees view
Okay.
is also clearly visible, madam.
Oh, there's something wrong with
It may
their
be that
phone.
there's something wrong with the signal, no? Maybe, I don't know.
Maybe their own, but we can very well
Their own.
see.
Right. Okay. So, so this is the standard 1020 system. This is the standard nomenclature that we would generally use. So each and every the EEG which you see now, of course, those days we used to actually have analog EEGs, which were paper based. Now we have moved on. Most of the centers in Sri Lanka now, at least the state hospitals, use digital EEG, where the analog system, the signals are now converted into digital. The advantage of actually converting these electrical signals into digital signals is it allows us one, versatility, and the second is this we can do some post signal acquiring. So after the signal, we can do some post processing to make sure sort of increase the sensitivity and the specificity of the EEG for certain conditions. So that is the main advantage of having a digital EEG. Right. So that is on electrode placement, and so it's a standard. Depends on so each the EEG technician would measure the distance between the Nasion and the Indian, and then divide it into these subsegments so that they will place the electrodes in the appropriate place. Right. So what is a montage? So often what we see on the left of a EEG paper or EEG sequence is you will see on the left is a montage, or it is the order in which the electrodes electrode potentials are reference against each other, right? So I've included some examples of some montages on the bottom of the screen, right? So for example, so there is this A1 electrode, right? And if you notice, all the electrodes there is you need two electrodes on what is measured is generally the difference between the potentials of two electrodes. So in this particular montage, we are referencing all the the electrodes on the left and the right to a single electrode, which is A1 on the left, right, and A2 on the right, right. So every potential is against that electrode on that particular hemisphere, right. Whereas the montage below, it's like a chain, right, where FP1 is measured against F3, F3 is measured against C3, C3 is measured. So it's the potential difference between the adjoining electrodes that are seen on the EEG. So this is an example for a longitudinal montage, and example for a reference montage is actually what I have already alluded to before. So there are various patterns that we use to measure the potential against other electrodes. And this pattern is called a montage. And why we use these various patterns is to improve localization and lateralization of the EEG signal, so that we are better equipped, or better where we are able to actually localize where the electric, mainly for these epileptiform discharges, where we try to, as much as possible, localize where the epileptiform discharges are coming from. So these montages are important in interpreting that. So coming to the basic steps, right, in any EEG is, as soon as you look at an EEG, your first glance is to look at the background activity, right? The first step would be to look at the background activity, right? Which is the overall picture of the EEG, right? And it's an overall sense of what's going on with the patient. Then you look at symmetry, because you should see whether there is any asymmetry between the right and the left hemisphere, right? And then also look out for how alert the patient is. For example, is the patient drowsy, sleepy, or awake? And there are changes in the EEG to suggest so. Also, often on the EEG technician will annotate whether this patient is awake or asleep or drowsy. And that's very important, because sometimes when we are interpreting the EEG, we can interpret sort of erroneously, where we might think that these patients have some epileptiform discharges, whereas actually the components that look like epileptiform discharges are actually changes that occur during sleep. So it's very important for us to actually understand whether the patient is awake, sleep, drowsy, or indeed unarousable. So it's very that has a bearing on how we interpret the EEG. And also then you look at any abnormal waveforms, which we will look into as we go along. So these are the four main steps that you would sort of perform when you are interpreting an EEG. So you look at the background activity, which is an overall picture of the EEG, or overall frequency of the EEG. Then you look at symmetry, whether there is any asymmetry between the right and the left hemisphere. Then you also look at whether the patient is alert, whether this, for example, is this an awake EEG, or is this a sleep EEG, or whether it has two components. So often our 20-minute EEG recording will comprise of mainly awake components, but we also do a few other things when we are recording the EEG. One is we try to see if the patient would fall asleep during or at least make sure that the environment is conducive for them to fall asleep, and there is a reason for that, and that is because when they fall asleep and they go into say N2 stage of non-REM sleep, there is activation of epileptiform discharges. And sometimes during an awake EEG, we are unable to pick up those epileptiform discharges. Whereas when these patients fall asleep, we might be able to pick up epileptiform discharges, especially when they go into N2 stage of sleep, non-REM sleep. So, an EEG or a typical 20-minute to 30-minute routine EEG will, the EEG technologies will try as much as possible to include both awake and transition to sleep, or at least light sleep, trying to activate any epileptiform discharges that might not be apparent during the awake EEG. Then there are other activation procedures that we would generally do, and which is standard, where we would sort of try to tell the patient to hyperventilate for approximately 3 minutes. And that is to exacerbate or trigger certain types of seizures. An example would be absence seizures, where which are triggered by hyperventilation. And also there are certain types of photosensitive epilepsies or epilepsy syndromes, which are triggered by photic stimulation, where we would flash lights into the patient and at different frequencies, starting from a low frequency approximately. There are different paradigms, but we generally start off with about 3 Hertz and then increase the photic stimulating frequency to around 30 Hertz. So those are called activation procedures. I'm not going to talk about activation procedures and what can happen during these activation procedures, because that is beyond the scope of this talk. However, just for your information, these are the things that we would generally do during a routine EEG and acquisition of the EEG data. Right. So, we'll talk about, before we talk about what is abnormal, we should know what is normal in a EEG. And generally, we look at the background frequency, the average frequency that this EEG would have. It's important for us to actually appreciate whether this is an awake EEG or a sleep EEG, or whether there is whether it's a transition between awake to sleep, and that is generally annotated at the bottom by the EEG technologies. So, and that because we need to know that to understand whether this background is normal or not, right? So, normal background in an awake EEG would have alpha activity, right? So, these are the main 4 types or different frequencies that in the waveforms. So you have delta, which is generally between less than 4 Hertz, or 4 waves per second, right? And then theta is where there is mild slowing, which is between 4 and 7 Hertz, right? Or 4 to 7 waves per second, right? And then we have the alpha, which is between 8 and 13 Hertz, and then of course the beta frequencies, which are greater than 13 Hertz. So this is an example for diffuse delta activity, which is this is the normal background, or not normal, but this is the background activity in a patient where there is diffuse delta activity, where you can see if these are the horizontal, so the vertical bars suggest the green bars are actually the time interval or the time base. So between 2 consecutive vertical bars is actually 1 second. And if you generally count, you can count here how many waveforms. You can see that most of it is 1, 2, or between 1 to 3 Hertz, which is generally delta activity seen on the EEG. So this is an example where the background has delta activity. We'll talk about whether it's abnormal or normal. Then this is theta. This is a little higher in frequency between the consecutive the green bars. So you will notice that now the frequency has increased, or is between 4 and 7 Hertz. And we have the beta range. I will talk about alpha activity in a little while. So beta range is a faster activity where there is these waveforms are greater than 13 Hertz or 13 waveforms per second. Right. So you need to look at the background. So what is normal? So you need to know what is normal. So these are just examples of delta activity, beta activity, and beta activity, which you can see throughout the page that this activity is sustained. So therefore, their background activity is of either delta, theta, or beta. Right. So these are just examples. Right. So what do we mean by normal EEG is normal background activity, which is alpha frequency in an awake individual who is an adult over the age of 18 years. So I'm not going to go into the various changes that occur during from the neonate to the infant to the child to adolescence, because there is a progressive change in EEG and EEG frequency of a normal background, and we generally reach adult um, frequencies by around 8 years of age. Generally, they start forming a normal alpha frequency by around 3 years of age, and then by 8 years, we'll have a normal alpha frequency. And if it's beyond 8 years and if the patient doesn't have a normal alpha frequency in the background, that is considered abnormal. Right? So, and nothing stands out in the background. So there should not be any abnormalities. As I said, no changes on the EEG provoked by photic and hyperventilation. Those are what we call activation procedures that we do during an EEG. And of course, no asymmetry. So what does a normal EEG look like? These are the factors that you need to consider. And when you're looking at a EEG, it has a what's called an antero-posterior, anterior to posterior gradient, right? The electrodes in front have a low amplitude, high frequency, and the amplitudes at the back, which are the occipital leads, will have a lower frequency and a higher amplitude. And this is what we call the anterior posterior gradient. So the main alpha activity is actually mainly observed. So in normal EEG in the posterior leads or the occipital leads, right? And that is quite normal for a, so this is what when we when a EEG is reported, we generally look for this posterior dominant rhythm where there is an antero-posterior or anterior to posterior gradient. And this posterior frequency of the leads which are in the posterior aspect, their frequency is generally between 8 and 12 hertz, which is the normal alpha frequency, right? And they are generally there is symmetry between the right and the left hemisphere. And if the amplitude is the difference between amplitudes is more than 50% between hemispheres, that is abnormal. And if there is a change in frequency of more than 1 hertz, because between both the hemispheres, there again that is considered abnormal or asymmetric. And of course, the patient generally during a 20 to 30 minute EEG recording should go into normal sleep. So they should have what we call normal sleep structure, architecture, where they have what we call normal sleep transients, right? We'll talk about them in a little while, right? Which are really sometimes with sort of mistaken for epileptiform discharges, which are actually normal sleep architecture in a patient who has actually fallen asleep. Right. So this is a normal EEG. This is actually a typical picture of a normal EEG. Right. Now, if you can notice, right, you can see this on the left is actually the montage, what we were talking about. So FP2 to F4 to O2. So you can see the first 4 channels are actually going from the anterior leads down to the posterior leads. So this is the montage is what we call a longitudinal montage, right? Where the ones in front, or the first lead is actually the leads which are in front or anterior, and the last leads are actually the leads in the occipital area. And if you see, and you notice that as it goes from anterior to posterior, the amplitude of the EEG signal has actually increased. So you can see that quite clearly here, right? And also this the alpha activity. This is alpha activity, and it is very prominently seen in the posterior leads. So FP means frontopolar, F means frontal, C means central, P means parietal, and O means occipital. And if these are the even numbers, so therefore these are signals coming from the right hemisphere. And you can see on the left hemisphere is the same configuration, and you can see that there are low amplitude fast activity or beta activity which is observed again in the anterior leads, which is FP1 and F3, and then we've got greater amplitude but slower activity, which is alpha range activity posterior, right? So this is what we are talking about when we said about antero-posterior gradient and what's called a posterior dominant alpha rhythm. And this posterior dominant alpha rhythm is seen throughout your life. And this frequency doesn't change even in the elderly. When you actually do a EEG, this frequency does not change. The other aspect that I wanted to highlight in this particular record is that you can see there is nice symmetry between the right hemisphere and the left hemisphere. So the first 4 leads are actually from the right hemisphere. The next 4 leads are from the left, and then the next 4 are again from the right, and then the last 4 from the left. So it's right, left, right, left. So you can see that there is, so what you need to do is you need to appreciate whether the frequency is the same. So you can see that the frequencies are more or less the same. You need to look at the amplitude as well. So whether there is a 50% change in amplitude, and if there is such an amplitude change, then there is asymmetry between the right and the left hemisphere. So there is no asymmetry. So this looks like that this is normal. Now, if you notice on the top of or the anterior leads, there is a drastic downward deflection that has occurred, right? These are what we call artifacts. So the EEG, the problem with EEG is that it is when interpreting, you have to always interpret it against a lot of artifacts, because there are physiological artifacts that or there are things that occur in the body that cause artifact on the EEG, and there are things that happen outside the body that can cause artifact on the EEG. So when you're interpreting the EEG, you have to always look at these artifacts as well. So this artifact, which is actually in the anterior leads, which is seen in FP2, F4, FP1, F3, FP2, F8, and so on and so forth. So these are what we call eye closure artifacts. So this is a patient who has what we also do this activation procedure as well, where we tell the patient to close the eyes and then we open the eyes, close the eyes and open the eyes. Why we do that is sometimes the alpha activity it becomes prominent on which is seen in the posterior leads, on the occipital leads, become prominent on eye closure, right? And so the EEG technologists will always use this activation procedure to see whether the background activity or the alpha activity is reactive. Right? Reactive means it's reactive to eye closure. So when there is no light coming in and there is no light stimulation of in the occipital area, there'll be increased alpha activity, which is a normal phenomenon in a normal awake EEG. Right. So again, an example of artifact. So when you're actually interpreting the EEG, you have to also look at these artifacts. So this is a typical eye closure artifact, again found in the anterior leads. So this, you see the montage on the left, right? And then you have these eye closure artifacts, which are occurring close together. These are actually EMG artifacts. So you can see these high frequency activity, which is seen right throughout, right? And this is what. So when the patient moves, when the patient is contracting the muscles, very often when they are contracting their frontalis muscles, their temporalis muscles, there can be EMG artifact in the particular leads that are overlying these muscles. So it's very important to identify that this activity is actually EMG artifact rather than actually epileptiform, or sometimes it is misinterpreted as ictal activity on the EEG. So we need to be very careful when we interpret these EEG, not so as not to make an erroneous diagnosis. Now, this is actually an example for ECG artifact. As you can, if you notice that there is a lead on right at the bottom, which is the ECG lead, right? So generally it is a requirement. If we are doing a proper standard, there should be a ECG lead as well, and that is to try to circumvent certain problems in interpreting the EEG. So you can see that the sharp waves that you see that are occurring periodically, this is not CJD, right? Which is occurring at 1 Hertz per second. This is actually ECG artifact. Now, so someone gives this for one of your OSCEs, this will be sort of diagnosed as this patient having CJD. But no, this is actually ECG artifact. We can see that this actually coincides with the ECG QRS complex, which is at the bottom. And so very important not to misinterpret these physiological artifacts which are seen on the EEG. So now I've spoken about what an awake EEG is like. So it has an anteroposterior gradient where you will see the prominent alpha activity in the posterior leads. You will see eye closure, and sometimes the eye closure might magnify the amplitude of the alpha activity that you see, which is quite normal in a patient. There is fairly good symmetry between the right and the left hemisphere, so on and so forth. So, and also we've spoken about the artifacts that can occur, and some of the examples of artifacts, eye closure artifacts, ECG, and the EMG artifacts. So now we'll talk a little bit about sleep, because often in a 20 to 30 minute routine EEG, as I said, we try as much as possible to make these patients have a small nap during the EEG recording. And these are some of the changes that can the physiological changes that can occur in a EEG. So you can see if the patient goes into the second stage of non-REM sleep, which is N2, they will have what we call this spindle activity, right? So these are spindles which are bursts of high frequency sinusoidal waveforms, which are found in the frontocentral region or frontal and central leads, which are basically originating from the thalamus, right? And that is if you find these on the EEG, this means that this patient has gone into the second stage of non-REM sleep. And these spindles can at times be accompanied by what we call K complexes, which are waveforms which are less than 4 Hertz. They're large amplitude transient waveforms, which has a single negative. Now, negative sharp wave means it's an upward deflection, and positive sharp wave means it's a downward deflection. So there'll be a single high amplitude negative or upward deflection and followed by a positive sharp wave, which is a downward deflection. I'll show you what these sleep transients look like in the following slide. Then, of course, there are these again K complexes and spindles are generally found in again the second stage of sleep, or N2. And then we have these posts, or what we call positive occipital sharp transients of sleep, or posts, which are generally less than 8 Hertz and seen exclusively in the occipital region bilaterally. And generally it occurs during the first stage of sleep, when the patient starts to feel drowsy, and then moving on to the first stage of sleep, and sometimes we see it in the second stage of sleep as well. These posts are triangular in shape and should not be mistaken for epileptiform discharges. Then we've got these V waves or vertex waves again, which can occur during the first stage of non-REM sleep, and they are maximal over the vertex, that is the central leads, which you saw on the 1020 system, right? So this is what a K complex would look like, and this is what a sleep spin would look like. And these are the various stages of sleep, starting from awake, which is again a background alpha rhythm, going to stage 1, where there is the EEG becomes slower, right? And there'll be what we call posts and vertex waves found in stage 1. Then we move on to stage 2, where you will observe spindles and K complexes. And then when we go on to stage 3, the background becomes much lower and in the theta range, which is high amplitude, right? And this is also called slow wave sleep, right? Or N3 stage of sleep, where there is a transition from alpha to theta activity. Now, so sometimes when you see this theta activity, and if there is no annotation, we would erroneously say that this patient is having encephalopathy without actually grading his level of alertness. So again, an EEG has to be interpreted in its context. So clinical context is very important. And then they can go back to alpha activity during REM sleep, right? So these are just examples of the vertex waves that I was talking about, and you can see, right? And these are sleep spindles, right? Fast activity sinusoidal frontal, which are frontocentral seen maximum for the frontal and central leads. And as you can see, this high amplitude waveforms which are less than 4 Hertz, which are called K complexes. Often the K complexes are associated with a spindle, right? And that's one way of sort of identifying that this patient is in stage 2 sleep. The examples are posts. Of course, you can see in the occipital region, which is T501 and T602. You can see these triangular sort of waveforms, which are called posts, positive occipital sharp transients. Then you can see these sharpened activity over the central leads, that is C3 and C4, which are vertex waves, right? And you can see the, sorry, these are again sleep spindles and K complexes. So you can see that these, if you're not careful, when we talk about epileptiform discharges, we would also see how similar these may look, and therefore they need to be interpreted in the context, and see, it's very important to know whether this is actually normal or abnormal. So when we've gone through what a normal EEG would look like. So that is the awake versus the sleep, and what kind of sleep transients or sleep architecture you will see, and also what the normal frequencies are during the various stages of sleep. And so that is part of observing the background activity. And then we've got the symmetry. Then we need to basically observe for symmetry, right? And that is the second step in interpreting the EEG, and that is between the right hemisphere and the left hemisphere. And this is an example of an asymmetric EEG, and you can see the context of the case at the bottom, right? You can see the montage on the left. So these are even numbers, so which means the first 4 leads on top are actually originating from the right hemisphere, and then we've got sorry, not the right. These are the odd numbers. So this is from the left, and then the second set of the 4 leads that are seen on the left, the montage, is actually originating from the right hemisphere. So you will notice that there is a marked asymmetry between the right and the left hemisphere. The amplitude is amplitude difference is greater than 50%, right? Because there's much greater amplitude on the right, and also you will notice that the frequency is in the delta range, whereas on the right, whereas the activity on the left is actually in the alpha range and looks quite normal. So this is a good example of asymmetry between the right and the left hemisphere, and this was a patient who had a right hemispheric infarction. And when you see this kind of asymmetry, you need to basically appreciate and look out for a structural lesion involving the right hemisphere. So that is an example of asymmetry. And basically, the 4th step. So now we've gone through the first 3 steps, that is appreciating the background activity. Then we go on to appreciating whether the EEG is symmetrical or asymmetrical. And also we've spoken about the level of alertness when we are during recording of the EEG, and what kind of changes. For example, now you know the changes that can occur during an awake EEG versus what changes to expect during EEG where the patient is sleeping and the various stages of sleep, changes that can occur during various stages of sleep. Then you need to look out for any abnormal waveforms, and the stereotypical abnormal waveforms that are generally seen are spikes and sharp waves, right? So spikes are very they are very sharp looking. They have a very sharp looking morphology, right? And so this is what one of the famous epileptologists was quoted to say: if it looks like you would sit on it and it would hurt, it's probably a spike. So it's a very sharply contoured spike, which is less than 70 microfolds in duration. Or less, right? And it has to stand out from the background. I'll tell you what that is, what that means, right? And then the sharp wave has a greater duration, that is between 70 and 200 microvolts, and again needs to stand out from the background, and it has a slope, and it's an asymmetric slope. So there is the upward deflection and the downward deflection are generally not the same. So the angulation is not the same. If it is the same, that is most likely you're dealing with something artifactual and not a true sharp wave, which signifies the possibility of a epileptiform discharge. Now, this is a EEG with an example of what we were talking about. So this is a sharp wave which is appreciated on. So you look at the left side of the EEG, you will see the montage, and you will see that these are odd numbers. So this is obviously originating this discharge or epileptiform discharge or sharp wave complex is actually evolving from the left hemisphere. And you can see that these are very sharply contoured, and if you look at the other sort of waveforms, you can see that this actually stands out from the background. And what generally happens is you can see that the background activity stops, and then after a while starts again, and that is what we call, what we say in EEG language is that background is actually disturbed because of this epileptiform discharge, and that happens in true epileptiform discharges, right, where this background activity is disturbed. The normal frequency and the morphology of the waveform or the background activity stops, and then you have this epileptiform discharge and then returns back a little later on. Whereas there are sharply contoured waveforms which resemble true epileptiform discharges where the background is not disturbed. And immediately after that sharp wave, there is resumption of the normal activity or normal background activity. That kind of sharp wave we would not take as a true epileptiform discharge. I hope that was clear. So this is an example for a sharp wave or a spike wave. Spike, which signifies epileptiform discharges, right? Then we have slow waves, which are generally more than 200 microvolts in duration. Again, stands out from the background. And if it is when you see slow waves, you need to decide whether these slow waves are actually whether it is focal or diffuse. Focal meaning are the slow waves confined to a certain region of the brain, looking at the montage on the left, or is this diffuse where the whole background is slower than what we would expect for a normal awake individual who is an adult over 18 years of age. So if you have a background of theta or delta, then most likely you are looking at a patient who is having encephalopathy of and that encephalopathy can be of any cause, starting from an inflammatory central nervous system etiology to a metabolic cause, for example, like liver failure, renal failure, where they've gone into some sort of metabolic encephalopathy. Of course, medication effect. And also, we also see this after seizures. So sometimes, and that can even last for 24 hours or more, depending on the duration and the severity of the seizure. We might see that the EEG might be slow or slower than we would expect in a normal individual. Dementias again can cause slowing in the regions in which the atrophy or the effect is most pronounced. For example, we might see some temporal lobe slowing or temporal region slowing in, for example, Alzheimer's. We might see some occipital lobe slowing in diffuse Lewy body dementia. So depending on the dementia, the slowing also or the theta to delta activity might be fairly regional as well. But as the dementia progresses, we will the diffuse the activity can become diffuse, right? And of course, in structural lesions which are bilateral, you will again sort of see this kind of diffuse slowing. Focal slowing, again, you need, if you see that kind of focal slowing or theta or delta activity which are confined to a certain part of the brain, then you need to exclude a structural lesion, which could have a broad spectrum from starting from subdural hematomas, tumors, stroke, hippocampus sclerosis, and so on and so forth. So, and also the focal slowing is also seen in focal epilepsies as well, and might show, give us a clue as to where the epilepsy is coming from as well. So this is an example or an EEG which shows focal slowing. You can appreciate the high amplitude activity which is seen over the frontopolar region or in the frontal region on the left. And that is an example for focal slowing. And you can see that it has also a morphology of a triphasic wave, which we will talk about in a little while. So these triphasic waves are also abnormal waveforms. It has again, as the name mentions, it has three phases, right? The main phase is surface positive, so which means that it's a downward deflection. The main waveform that you'll generally see is a downward deflection which has a higher amplitude compared to the two deflections, negative deflections or upward deflections. So you will have low amplitude negative deflection, and then first, then very high amplitude downward deflection, followed by again another low amplitude upward deflection, which is the typical morphology that we will see in a triphasic wave. Generally, it indicates that this patient may have metabolic and toxic encephalopathy, but can also be seen in patients who are having non-convulsive status. So you need to be very careful in how we interpret these, whether this is actually a patient who's actually in encephalopathy or whether this patient is actually having non-convulsive status. There are other EEG criteria that we generally look out for, but we need to again look at it in a very contextual manner. Again, the patient may have the patient with triphasic waves may signify mild to moderate encephalopathy. Can be seen with certain types of drugs such as kefepime, and also certain drugs such as lithium intoxication. Also, you might be able to see this kind of waveform. Of course, the typical encephalopathy would be the toxic encephalopathies, and also liver and renal diseases causing metabolic encephalopathy. Right. So these, as I said, so if you look at the screen here, these are the typical triphasic waves where we see the first we have the positive deflection. The negative deflection, which is an upward deflection. Then we have the high amplitude the positive deflection, which is again a downward deflection, and then more less sharp upward deflection, which is a negative deflection. So this is the typical morphology that you will see in triphasic waves, and may signify that this patient is in moderate level of encephalopathy, which may be maybe a metabolic encephalopathy, but it is not specific to liver pathology, which I think most people might be erroneously aware. Then, of course, we have the PLEDs, which are called periodic lateralizing epileptiform discharges, which occur throughout the entire EEG at a fixed frequency of between 1 to 2 hertz, and is generally confined to one hemisphere, and generally seen in structure, can be seen in structural lesions such as stroke and intracranial hemorrhages. Can be also seen in as part of a postictal phenomenon, and also we all know about the HSV encephalitis that we all look out for, and also CJD is another example of where we will see these PLEDs, and you can see on this EEG how it lateralizes, where these epileptiform discharges are actually confined to one hemisphere, which is seen on the left, and it's very periodic, occurring at frequent at intervals of between 1 to 2 hertz, seen across the EEG. So this is a morphological example of what the PLEDs would look like, right? And so in summary, EEG is a very useful tool in the evaluation of patients especially with seizures, but other conditions as well. It has to be used in the true clinical context, and there should be a proper indication of doing EEGs. Both spikes and sharp waves are referred to as interictal epileptiform discharges, but not always suggestive of epilepsy. Strokes, conditions like strokes can be seen on EEG as well, but EEG should not be a way of identifying strokes. And most importantly, to appreciate whether the EEG is abnormal, you need to appreciate what is normal. And this is anterior, and therefore you need to appreciate the anterior to posterior gradient, posterior dominant rhythm, and also see whether the background rhythm is on the background frequency is symmetrical or not, and if possible, if the patient is goes to sleep, whether there is normal sleep architecture or not. Okay, I think that's all I have to say. If there are any questions, I'm happy to answer.
Kishara, there's a question. You can see Q&A one.
if the EEG starts with the right side, and slow wave seen on the infarcted side. So, slow wave seen on the infarcted side, showing the infarct be on the left side as per your diagram. If the EEG starts with the right side, it may be about the asymmetry, no? I'll go back to the slide, I suppose, no?
Yeah.
They must be talking about. Must be this one, no? That they are talking about. Now, actually, I think I probably made a mistake. You can see that the right hemisphere, this is the FP2, F8, T4, these are all odd numbers, sorry, even numbers. So these leads that involve the right have the amplitude is much slower than we would expect, and the frequency and the amplitude, frequency is much less, and the amplitude is greater than the other side, or the left side. So which would mean that the abnormality lies on the right side, right? So in the context of a right hemispheric infarction, this is what we would expect on the EEG. I hope that's clear.
Yeah. If you have any questions, you can type in chat box or Q&A.
Is there a clinical indication to put the patient on anti-seizure medications? What is the place of EEG in that situation, considering the fact that EEG is not readily available and we should usually start them on treatment? What is the place of EEG situation? The fact that EEG is so EEG is so it's a very good question. So EEG is a tool which we use for two things, right? So if in the case of a new onset seizure where the patient has sort of experienced a single seizure, the EEG is a tool which we use to predict recurrence, right? So if there are epileptiform discharges, right, in a patient who's got a single seizure, that particular person will have a higher risk of recurrence, and therefore you will be justified in starting a patient on anti-seizure medication. So the EEG utility for that particular situation is to predict whether the patient is going to have another seizure or not. The EEG often is not used. So the second indication for a EEG, especially in the setting of epilepsy, is to classify whether the seizures or the epilepsy is of either focal onset or a generalized onset or generalized epilepsy. And to classify or give a syndromic diagnosis to the epilepsy. Now, EEG is not necessary for you to diagnose epilepsy at all, right? If a patient has epilepsy, right, there are three diagnostic criteria, operational criteria. One is that if you have had two seizures, right, and you are clinically diagnosed that these are two seizures with a proper history, right, you don't need a EEG to start this patient on anti-seizure medication, right? You need the EEG only to, so EEG is not a tool to confirm or refute the diagnosis, because a routine EEG, generally the 50% of the routine EEGs in a patient with epilepsy, even with true epilepsy, the EEG will be normal. And that is an important fact that every trainee has to bear in mind. So, just because a patient has a seizure, EEG will not either confirm or refute that diagnosis. The only way you make a diagnosis of epilepsy is by taking a good history, right? But the EEG is useful, one, to assess whether this patient is going to have recurrence. Second is to classify the syndrome if these patients have epileptiform discharges. I hope that is clear. So when you start anti-seizure medication, it is you have to make a clinical diagnosis based on your history, not based on the EEG. I hope that's clear. Then, are there any drugs, sedatives we should avoid in a patient awaiting EEG, for example, in an ICU patient who might need some sedation? Yeah, no. So you don't have to avoid. You just need to mention what kind of drugs this patient might be on. So, for example, if the patient is on, whether the patient is on benzodiazepines, where the EEG might be altered. So, for example, you will, if a patient is on a benzodiazepine or a barbiturate, the EEG frequency can increase to the range, to the beta range. So there might be excess frequency that we see on the EEG. Without the knowledge that the patient is on this particular drug, we might erroneously diagnose this patient as having, say, a beta coma or beta frequency coma, right? So the diagnosis again is contextual. So you don't need to alter medications, but maybe you need to mention that in your request form that this patient is on these particular drugs, which can sometimes alter the EEG and alter the interpretation. Can you explain burst suppression? Right. Okay. Right. So burst suppression is a burst of waveforms where the amplitude is high, and all of a sudden the EEG background is suppressed. I'll try to give you an example. Can I share that? Wait, hang on. Oh, a picture burst suppression. Yeah. Can everyone see this? Yeah.
Yes.
Can see, no? Yeah. So you can see, so this is an example of burst suppression. You can see that there is some activity here where there is a high amplitude, say delta activity, and sharpened, so epileptiform discharges as well. And then all of a sudden, the background activity is completely suppressed. You can't, the amplitude, you can't see any waveforms, right? And this particular area is now under suppression. And then you have another sort of high amplitude activity. This is an example for burst suppression. So we see burst suppression or suppression burst activity, especially when we treat patients with status epilepticus. One therapeutic where we have the epileptiform discharges, we will suppress the activity for about 12 seconds, and then you see the burst of around say 5 seconds. So 1:2 kind of suppression. So this is one way of titrating our and sort of anti-seizure medication as well as the anesthetic, so to sort of give this kind of EEG target. the other thing that we see as burst suppression, or the other example that we would commonly see in clinical practice is in ischemic, hypoxic ischemic encephalopathy, where this is generally considered grade 5 on EEG criteria, which is very severe encephalopathy. The patient has extremely poor prognosis. So this is an example for burst suppression. I hope that is some more questions. How is sedation? How is the sedation affects the interpretation of EEG, especially in agitated patients? What is the preferred sedative medication if it is not possible without sedation? So sedation, as I said, it depends on the agent. So if you give a benzodiazepine, as I said, that can have an effect on the EEG where there will be excess of beta activity. We can still interpret the EEG. If the patient is still aggressive, you can give give a benzodiazepine or any other medication, as long as you mention what the medication is. So it's important. Obviously, you can't have a patient who is agitated and moving around, because the EEG interpretation also will be affected, because when the patient moves around, there will be what we call EMG artifact. So again, the EMG artifact can affect interpretation. Can you please show the pled again? Okay, I'll show the pled again. Can you see the screen? I suppose you can. Yeah. So this is the pled again. So the whole idea is that these epileptiform discharges occur at periodic intervals. So the interval in between two epileptiform discharges is more or less equal, right? So that is what we mean by periodic. So it occurs at periodic or very stereotypical intervals. Otherwise, and it doesn't always mean that this is an epilepsy that you're. It's very controversial. It's generally a structural lesion that we are looking at when you see pleds. Okay, are there some more? No, I think I've answered all the questions.
Yes, Kishara. Thank you very much for this interesting talk. Actually, you have simplified very complex thing within a very given period. Thank you very much for spending your time. And we have very good audience, like 82 people there for throughout. Thank you very much, Kishara, again. And I would like to thank all the audience and Mr. Dishan Fernando for IT support, and Gets Pharma for sponsoring this. And I would like to take this opportunity to tell all our senior registrars, you can go to the SLCIM website and get your membership and be a member of Sri Lanka College of Internal Medicine. And if you want to watch any other senior registrar forums we have done so far, or any other activities, it is there in the website. Thank you very much. Have a very good night.
Thank you.